Awesome. So, good afternoon, everyone. My name is Dr. Dominique Finn. Thank you for joining me today. I'm really committed to addressing the Black maternal mental health crisis. So, my work is really rooted in ecological systems theory, culturally responsive practices, and community-led solutions. I'm the founder of Black Dot Births That Matters. We really center around Black moms and Black birthing people and making sure that they are getting the birth equity that they deserve. So I kind of do this through reproductive justice, education, and advocacy. And also I do, the micro level work as well. So today's presentation is going to explore how ecological systems theory, I'll refer to it as EST for the purposes of this presentation, can help us better understand the systemic nature of maternal health disparities, especially among women of color. We'll analyze one case study in depth and then also evaluate how community-based doulas act as a multi-level intervention to support birthing people and families navigating unjust systems. So with that, I want to give some learning objectives. So first, we'll explore the four levels of Bronfman-Bronner's ecological systems theory and how each uniquely kind of contribute to the disparities in the maternal mental health outcomes for women of color. Second, we'll analyze the case of Ashley Brown, a composite case that's grounded in like real life clinical and community context to understand how intersecting systemic barriers really impact her and her physical and mental health during and after pregnancy. And finally, we'll evaluate the effectiveness of community-based doulas, how they operate across ecological layers and serve as a culturally responsive, equity-driven intervention. So let's just start off with a brief little introduction. So maternal health disparities in the US are deeply systemic and proportionately affect women of color, particularly Black, Indigenous, and Pacific Islander women. These disparities are not new, and they are embedded in a long history of structural racism, inadequate healthcare systems, and a lack of culturally congruent care. So factors such as socioeconomic status, racism, implicit bias in healthcare settings, and geographic access to care all intersect to produce devastating outcomes. So EST really gives us a powerful framework to really examine these multi-layered influences and to move beyond individual responsibility towards structural accountability. So we're really going to highlight the role of community-based interventions and who and how this really supports birthing people at every stage. So we're going to watch a short little video about about an incident that happened to someone.
The autopsy report is in for three-time Olympic medalist Tori Bowie. The track and field champion was found dead at her home last month.
According to the report, the 32-year-old died from complications of childbirth, but her agent says she was not actively performing a home birth when her baby started to arrive. This is bringing the conversation about maternal mortality rates front and center again, specifically for Black women.
Life can change at the drop of a dime. So I just try to stay in that appreciative state of mind.
Those haunting words from Tori Bowie during a 2017 interview. According to the medical examiner's report, the 32-year-old was about 8 months pregnant and had been undergoing labor when she died. Her autopsy noted there had been possible complications.
So sorry. I don't know what just happened.
The autopsy report is
Performing a home birth when her baby started to arrive. This is bringing the conversation about maternal mortality rates front and center again, specifically for Black women.
Life can change at the drop of a dime. So I just try to stay in that appreciative state of mind.
Those haunting words from Tori Bowie during a 2017 interview. According to the medical examiner's report, the 32-year-old was about 8 months pregnant and had been undergoing labor when she died. Her autopsy noted there had been possible complications, including eclampsia, defined by the CDC as a medical emergency.
Extreme increases in blood pressure, and most importantly, seizure. Seizure can lead to loss of consciousness, respiratory depression. If the blood pressures are very high, even stroke, and in this case, death.
Doctors we interviewed say they did not treat her and don't know the athlete's medical history. But according to the Centers for Disease Control, in the United States, federal data shows the nation's maternal death rate rose significantly in 2021, with rates among black women more than twice as high as those of white women.
We really are all the same. Our genes are pretty much the same. It tells us that there are societal components that impact the health outcome of a patient. Now, I can't necessarily say that was happening to Tori.
Dr. Antonia Oladipo is an OBGYN.
And it's your lived environment, right? It's the interactions around you. It's the stress that you feel every day that puts you on edge because maybe you're concerned that you might get pulled over from the car and maybe get shot by police versus maybe you won't, right? That actually, all those stressors change your cellular makeup so that wears you down.
Shakaya Cross is pregnant and due in a month.
I had a lot of pain in my leg, got swollen, I couldn't walk.
She said she had pre-eclampsia in her first trimester.
Preeclampsia is basically an increase in your blood pressure after about 20 weeks. And most of the time, it's well managed if it's identified, treated with blood pressure medicines.
In the United States, the CDC reports the rate of preeclampsia in black women is 60% higher than white women. Cross says she only got the diagnosis after going to a hospital after she felt her doctor dismissed her, and has this advice for other black women: advocate for yourself.
Be aware any problems that they have to definitely speak up, do research.
Women really need good care. Every single woman should be prioritized.
Well, sadly, Bowie's unborn child also did not survive. Her agent says Bowie did not trust hospitals. The Orange County Sheriff's Office responded to a home in Florida, her home, for a well-being check on a woman who had not been seen or heard from in several days, they said.
Okay, one of the things that I also want to just add on about that video, that nobody is spared from the maternal mental health crisis. So if it can happen to Olympian, it can happen to anybody. Just to add, Serena Williams is also another public figure that talks about her struggles of having stuff happen and the doctors not listening to her, and as she almost died having her second child. Beyonce is another person that talks about having complications during birth and the doctor's not listening to her and her almost dying. So I say that to say that it can happen to anybody, whether you're famous, whether you're not famous, it can happen to any of us. So with that being said, let's look at some data real quick. So in 2022, Black and American Indian, Asian Native women experienced maternal mortality rates more than 3 times higher than white women. So that's 63.4 and 55.9 deaths per 100,000 live births, respectively, compared to 18.1 for white women. Women of color are also significantly more likely to experience preterm births, low birth weight for infants, and inadequate prenatal care. All factors that affect both maternal and infant outcomes. Infant mortality also follows a similar pattern. So infants born to Black, American Indian, and Alaskan Natives mothers are also far more likely to die before their first birthday than those born to white mothers. So these disparities persist across income, education, and it really shows us that racism, not race, is the driver. So in 2020 alone, nearly 900 women died from pregnancy-related causes in the United States. Deaths occurred across the perinatal continuum, so 26% during pregnancy, 27% during birth or the first postpartum week, and up to 47% in a year for postpartum. What's staggering is that in 84% of these deaths, they were preventable. That means with the right intervention, support systems, and policies, the vast majority of these mothers could still be alive today. One of the most under-addressed areas in maternal care is mental health. In a review of maternal deaths across 38 states, mental health conditions emerged as the leading cause of pregnancy-related deaths, particularly due to suicide and overdose. So this really highlights our need for integrated trauma-informed mental health care throughout the perinatal period. And with that, I want to talk about my case study, Ashley Brown. So, Ashley Brown is a 32-year-old African American woman facing severe maternal health disparities. Her case highlights the intersection of race, socioeconomic status, and healthcare inequalities in maternal mental health and maternal health. She was referred to a clinic by her primary care physician due to anxiety and distress following childbirth complications. Ashley, Ashley experienced gestational diabetes and hypertension during her first pregnancy, which went undiagnosed due to barriers to healthcare access. This led to severe hemorrhaging during childbirth and long-term maternal health issues, including persistent hypertension and anxiety. Ashley was raised in a low-income household, and Ashley struggled with healthcare costs, which limited her ability to receive quality prenatal and postnatal care. And due to systemic barriers, including inadequate healthcare coverage, lack of culturally competent providers, and transportation challenges, she has faced difficulty in receiving consistent care. A small support network with minimal family involvement has increased her vulnerability, making it harder to manage stress and navigate the healthcare system. Ashley has been diagnosed with postpartum hypertension, anxiety disorder, and trauma related stress disorder stemming from her childbirth experience. The emotional and physiological distress from her experience impairs her daily functioning, exacerbates stress, and contributes to long term health risk. She's currently in treatment for both hypertension and anxiety. And to address trauma related symptoms, anxiety, and stress associated with her childbirth, she's currently in therapy. Social workers and healthcare providers are working to connect her with affordable maternal health programs, culturally competent providers, and mental health support services tailored to women of color. By integrating medical, psychological, and community-based support, the goal is to improve her health outcomes and overall well-being substantially. So that brings me to ecological systems theory. So Brownfriend Bronner's EST reminds us that individual development and well-being are shaped by layered systems. So let's briefly review the systems. So we have the microsystem, which is the individual and immediate environment. So that's home, family, workplace, healthcare. We have the mesosystem, the connections between the microsystems, like how Ashley's work schedule interacts with her ability to attend perinatal appointments. Then we have the exosystem. This is the internal systems that indirectly affect individuals. So healthcare infrastructure, job benefits, public assistance programs. Then we have the macro system, the broadest system. So that's social norms, policies, and systemic racism. So Ashley's experience is not just a micro level issue. It's shaped by multi levels of disadvantage working together. I'm not talking about the chrono system here, but that's also a level in the ecological systems theory. So at the micro level, Ashley's health was affected by her personal stress, low income, and limited support system. So these challenges directly reduced her ability to maintain perinatal appointments and adhere to treatment plans and engage in self-care. Transportation barriers, like I said, meant she often missed follow-up visits and she lacked consistent support from her partner and didn't have a family network nearby. The financial strain made it hard to afford nutritious food or perinatal vitamins. So this level helps us understand that individual challenges are often symptoms of broader systemic failures, not personal inadequacies. So in the meso level, It looks at how we said different parts of a person's immediate environment interacts with each other. So in other words, the connections between two or more microsystems. So for maternal health, this often means the bridge or the gaps between a woman or a birthing person and a birthing person and their community resources, including local healthcare services. So in many underserved communities, the quality and availability of healthcare are often limited and inconsistent. So for instance, Ashley lives in a neighborhood where community resources such as clinics, perinatal classes, or support groups are very scarce. If a clinic exists, it might be understaffed or have long wait times. If there's a public health program, it might not be well funded or effectively reaching those in need. The lack of access quality care at the community level is a classic meso level problem. Hill et al. 2022 provides evidence of the crucial role this meso-level plays. Hill and colleagues noted that in areas where healthcare infrastructure is weak, especially in culturally diverse communities, the available care often lacks cultural competence. And we know that cultural incompetent care refers to healthcare services that don't adequately respect or understand the cultural background of patients. So, for example, failing to account for language differences, dietary habits, or mistrust stemming from historical injustices. So Hill et al. 2022 analysis found that such deficiencies in care lead to poorer maternal outcomes for women of color, especially when providers don't or can't meet patients where they are at. Ashley struggles to find quality prenatal care are a direct reflection of these meso-level issues. She might have faced clinics with no staff who looked like her or understood her background. Perhaps provider who dismissed her concerns, an issue many Black women report, or clinic hours might have conflicted with her work schedule, and they offered no flexibility. These are systemic community level issues not caused by Ashley, but definitely are impacting her. Moreover, the meso level illustrates compound effect of micro level issues feeding into community level issues. So now let's talk about the exo level. So factors like workplace policies, regional infrastructure, and broader social services are the exo level problems that we're talking about. So, for someone like Ashley, who is directly navigating pregnancy, exo level influences might seem removed, but they can profoundly affect her access to care and resources. So, let's consider employment. If Ashley's job doesn't offer paid maternity leave or flexible hours for medical appointment, she's in a bind. She may have to choose between keeping her job and caring for her health. Many women in low paying or part time jobs lack job security or even benefits, meaning taking time off for perinatal visits could jeopardize their income. Or let's think about regional infrastructure. What if the region she lives in has no nearby hospitals with OBGYN services? Think about it. In many rural or economic disadvantaged areas, hospitals have closed maternity wards due to costs, forcing women or birthing people to travel far distances to give birth or receive perinatal care. So if public transportation is also lacking, as it was in her case, that's another blow. We saw a hint of this in her micro level concerns. And then there are social services. Perhaps Ashley qualified for nutrition assistance or housing support. But if those struggles are difficult to navigate, are underfunded, or have long wait lists, they might not actually alleviate her struggles in time. So research done by ASWB 2020 gives insight in how these exo-level factors can shape perinatal health. His study indicated that when women lack job-based health benefits and face obstacles in accessing social support programs, their perinatal health really suffers. So if a pregnant woman doesn't have health insurance through her employer, which is common in many low-wage jobs, she might skip necessary doctor's visits. Or if she can't access a community program for expectant mothers, she misses out on valuable information and support. These indirect systems, like employment benefits and social services, might not be immediately visible in the day to day, but they definitely create the context in which all of Ashley's micro and meso experiences play out. So Ashley's scenario, we can imagine that her financial stress was partly due to an inflexible job with no maternal benefits, an EXO level issue. Maybe she wasn't aware of any social programs that could help her, or those programs simply weren't reaching her effectively. So we've seen individual, community, and external systemic factors. Now let's address the broadest category, which is the micro level influences. So one micro level influence is health policy. So policy really determines who has access to healthcare and what kind of care is covered. So we should consider how Medicaid expansion or the lack thereof in different states really affect pregnant women or birthing people in states that haven't expanded Medicaid under the Affordable Care Act. And now we know that there's also the big beautiful bill that will be also affecting Medicaid and Medicare people. So many low income women might fall into a coverage gap during or after pregnancy. If policies restrict funding to maternal health programs or clinics, communities like Ashley's suffer. So the National Partnership for Women and Families 2020 issued a policy brief highlighting how certain restrictive policies effectively limit the access to essential maternal care services, which directly contributes to higher risks for women of color. So if there's a lack of funding for maternal health clinics in predominantly Black hoods, that's a policy decision, leaving a dangerous void in care. Then there's structural racism. Taylor et al. 2019 discusses how racism is not just about individual prejudice, but it's really built into healthcare systems. This can manifest in countless ways. Hospital systems that primarily serve Black and Brown communities being under-resourced compared to those serving white affluent communities. Medical training that doesn't cover bias, leading to doctors dismissing Black women's pain or symptoms, or means that even broader economic policies that keep certain neighborhoods impoverished, affecting the residents' health. Structural racism means the deck is stacked systematically. So in Ashley's life, this might have meant she attended a clinic that was underfunded, overcrowded, where she sensed discrimination, all because the system had long neglected a community like hers. So in summary, macro level factors like national healthcare infrastructure, economic inequality, and ingrained racism create the backdrop against which all other levels operate. Ashley's individual struggles, micro, her community's challenges, which is the meso, and the external systems, which is the exo, are all either exacerbated or alleviated by what happens at the macro level. When policies are inclusive and equity driven, individuals like Ashley get more support. When the opposite is true, they face uphill battles at every turn. Ashley's experiences encapsulate how institutional barriers, whether they be policy driven or arising from enriched social inequalities, can significantly harm maternal health for women of color, often unseen but in powerful ways. Having dissected these layers, Influencing maternal health, we should now acknowledge what the research is still trying to understand and where future inquiries are headed. So, while we have discussed the various factors at different levels of EST affecting maternal health, it's important to note that our understanding is still incomplete in some areas. So, there are definitely gaps in the research that need to be addressed to fully comprehend and tackle maternal health disparities. One gap lies in understanding how EST layers interact with one another. So we're still talking about the micro, the meso, the exo, and the macro as distinct layers for analyzing and getting that clarity. However, in reality, these layers are interweaved and influence each other dynamically. So, for example, and how exactly do macro level issues like residential segregation intensify micro level problems like stress or access to nutritious food during pregnancy? So researchers are examining these intersections. And for example, Mera et al. 2017, for instance, investigated how macro level conditions such as racial residential segregations correlate with adverse birth outcomes. They suggest that women living in highly segregated areas face compounded risks that echo through the micro and the meso levels. Perhaps through reduced local investment, through fewer hospitals, and higher stress levels. But more research is still needed to unravel those pathways clearly. Another gap is the limited number of studies that directly connect the lived experiences of women of color to the EST framework. We have statistics and broad studies, but personal narratives like Ashley's aren't always captured in large scale research. So, Howell 2018 et al. Pointed out that bridging this gap is crucial. Their work hints that when research directly involves women of color and grounds the inquiry in their realities, the resulting highlights can lead to more targeted interventions and validate the experiences these women have been voicing for years. Essentially, qualitative insights and community-based I always never say that word right. Participatory research can enrich our quantitative findings. So, et al. Argue that by connecting personal stories to a systemic analysis, we can better design interventions that resonate culturally and practice with those who need them most. So, in summary, future directions for research involve not just looking at EST layers in isolation, but also understanding how they compound and interact. Also, the research community is recognizing the importance of involving women of color in research about them. So, ensuring that their voices guide the questions asked and the solutions proposed. Filling these gaps will help us craft interventions that address the right problems at the right level. So, speaking of interventions, let's move to what can be done, particularly how community based interventions like doula programs align with EST and can help address these disparities. So, having identified, right, the layered challenges, we're now going to explore an intervention that inherently works across these layers, and that's a community-based doula. Doulas are trained professionals who provide continuous physical, emotional, and informational support to mothers or birthing people before, during, and shortly after childbirth. So, a community based doula is typically from the same community or cultural background as the mother or birthing person that they serve, making this support culturally responsive and trust building. The role of a doula is non medical, but highly complementary to medical care. So, doulas help navigate healthcare systems by informing mothers or birthing people of what to expect, advising them on how to communicate their needs to doctors, and ensuring that they understand their rights and options. In communities of color where mistrust in the healthcare system can be high due to historical abuses and ongoing discrimination, a doula who shares the social or cultural background of the mother or birthing person can bridge gaps in that communication and understanding. So the mother or birthing person feels seen and heard. The doula can advocate on their behalf if needed. So, for instance, reminding a busy nurse that the mother or birthing person hasn't been checked on recently or asking for clarity on medical procedures. And research backs this up. So, a study was conducted and it said linking doula support will better birth outcomes. Specifically, they found doula involvement is associated with lower risk of preterm birth and fewer cesarean deliveries. So these outcomes are particularly valued for women of color who statistically face higher risk of preterm birth rate and C-sections, sometimes unnecessary ones, as some research suggests bias in clinical decision making. The study also implied that doula care can be cost effective by preventing complications that lead to expansive interventions or or NICU stay. So in essence, community-based doulas operate at multiple EST levels. So at the micro, a doula provides direct individual support, boosting the mother or birthing person's confidence and knowledge. At the meso level, the doula connects the mother or birthing person with community resources, possibly referring her to local clinics, food programs, support system, or mental health services. The EXO level, while the doula might not change Ashley's jobs policies, for example, she can help Ashley make the most of available social programs or find workaround solutions like scheduling appointments during lunch breaks or linking with charities that provide transportation to perinatal visits. And at the macro level, doulas collectively are advocates. Many community doula programs are involved in pushing for policies like Medicaid coverage for doula services, which is a policy move a lot of states have done. So this really underlines that community-based doulas are especially effective for women of color at higher risk for these adverse outcomes. Why? Because doulas understand the context, the potential mistrust of medical providers, the financial or transportation issues, the cultural practices around birth, and they tailor their support accordingly to each individual. It's not a one size fits all model, it's a personalized, community sensitive approach. So, to illustrate this, let's revisit Ashley's case and briefly and imagine how community based doula might have helped her in her situation. So now we return to Ashley, our case study, to understand how a community-based doula could make a difference in a situation like hers. So with the barrier for financial hardship, Ashley's limited finances meant she often had tough decisions to make. So perhaps between taking time off of work and losing income to attend a perinatal visit or skipping to save money, a doula can't magically pay her bills. But what a doula can do is connect her with resources. So like I was saying, doulas often know about local non-for-profit or government-based programs that can connect her to resources. So maybe she could find free prenatal classes or nutritional support. A community-based doula might have helped Ashley fill out applications for WIC or find a sliding scale clinic. In doing so, the doula guides Ashley through the financial labyrinth, ensuring her money or their lack thereof is less of a barrier to care. So with limited social support, Ashley was pretty much on her own socially. A doula becomes part of her support network now. So this is personalized guidance and advocacy. So the doula could visit Ashley at home, talk her through certain concerns, perhaps even involve Ashley's partner or family members if available to educate them on how to support her. Doulas often say they mother the the birthing person or the mother, which means providing emotional support, a listening ear, and reassurance by simply just being there consistently. And it also reduces Ashley's sense of isolation. So, for the systemic biases in healthcare, Ashley likely encountered providers who dismissed her pain symptoms, something that many Black women report. A doula can bridge the cultural and communication gaps between Ashley and her healthcare providers. So, for example, if Ashley feels too intimidated to ask a question or express a concern to her OBGYN, the doula can either coach her on how to ask or even raise the concern on her behalf with Ashley's permission. So the doula stands as an advocate at appointments, making sure Ashley's concerns are heard and respected. If a provider is rushing, the doula might potentially slow things down by asking for clarification, which indirectly signals that Ashley deserves time and clear information. So in summary, a community-based doula acts as an intermediary. So they really helped build trust between Ashley and that healthcare system. They ensure comprehensive care by making sure nothing falls through the cracks, whether it's a missed referral, an unasked question, or an unspoken fear. For Ashley, having a doula might have meant the difference between feeling powerless and feeling empowered throughout her pregnancy and childbirth. Now, while doulas offer great promise and scaling up such interventions is not without its challenges, let's discuss some of the challenges and future directions. So, one of the things that we can talk about is the limited funding. So many doula programs, especially community-based ones, rely on grants or donations. Stable funding is a huge challenge. So without consistent financial support, doula services often can't reach all the women or birthing people who might benefit. So one solution being discussed is integrating, as we know, doula services into insurance coverage. Here in New York, doulas are now covered on Medicaid. So our lower income people can benefit from that service. But the problem is everybody is not able to be covered by doulas on their Medicaid, on their insurance. So that's where some of the challenges come in. And then the other challenge is, although you're covered, the waiting list may be long. So different like access that is definitely tough to kind of navigate. Also, to be effective, doulas also need training, especially to handle diverse situations to coordinate with medical teams. So right now, access to quality doula training can be kind of uneven. If you live in a big city, you might find a training program, but in rural areas or certain states, it might be hard to find a culturally competent doula training organization. There may also be costs associated with training that deter interested individuals. So this points to the need for standardized training and certification processes that are accessible and possibly subsidized. If we want more community doulas out there, we have to train more people from those communities to do the work. Doulas also work in various settings. So some are dependent and some are attached to hospitals, and some work with non-for-profits or community health cares. There was a research study that was done, qualitative research with community-based birth doulas, and found that they operate in very diverse contexts. This proving their worth to the skeptics. Without standardized metrics or models, it's harder to convince a hospital or a government program to adopt doula services because they might say, well, how exactly will it work here? So this study really suggests that sharing best practices across these settings will definitely help. The other thing that I want to say, beyond insurance, policies could be enacted to include doula in maternal care initiatives formally, and a state could mandate that all birthing hospitals have a referral program for doula services, or federal government could include doulas in maternal health improvement plans. Legislation like the Mombis Act, it really built a bill in the Congress that has provisions to fund community-based organizations working in maternal health, which includes doulas. So policymakers can help by allocating funds, creating pilot projects, and removing barriers to entry for community members to become doulas. So in essence, doulas have the potential to basically operate across all levels of EST, as we mentioned. Empowering mothers individually strengthen or birthing people really strengthen community support networks and even advocating for systemic change. But to fully realize this potential, we need to overcome funding hurdles, making training widespread and standardized, and realize this potential. So, in conclusion, applying ecological systems theory to Ashley's case provided a structural framework for understanding how these factors interact and build upon one another. We observed that individual factors, say Ashley's health, literacy, or stress level, are often impacted by community barriers like how far she has to travel for a prenatal checkup, and are both influenced by systemic issues. So EST essentially helped us map out the chain of influences and see that to improve maternal health, interventions cannot focus solely on one level. If you only address Ashley's individual behavior without fixing the clinic availability in her area or the insurance coverage, you'd fall short. Likewise, a policy change alone might not be enough if Ashley does not have the support to navigate the clinic. So this brings us to a community-based doula as a response. Doulas, being culturally competent and community rooted, directly address some micro level issues by providing Ashley with support and information, meso level issues by connecting her to community resources and making local healthcare interactions smoother. By helping clients navigate systems and advocating for better care, they indirectly contribute to addressing macro issues as well, especially if the movement gains momentum and influences policy. Another key role of doulas is fostering social support and empowerment. Remember, isolation was one of Ashley's problems, and a doula helped reduce that isolation by creating a supportive relationship. This can mitigate stress, which is not a small thing. Chronic stress is known to contribute to poor birth outcomes like preterm labor. So even at the level of stress reduction and emotional well-being, doulas have an impact. So in sum, Ashley's case wasn't just about one woman's ordeal. It exemplified how multi-level failures lead to tragic maternal health outcomes. Yet the introduction of community-driven solutions such as doula care presents a multi-level remedy, empowering the mother or the birthing person, strengthening the community ties, and hopefully inspiring changes to the healthcare system. Finally, let's discuss the broader implications and a call to action on the last slide. So to wrap this presentation up, I want to emphasize why community-based doula programs matter and outline some calls to action. They really do address mental health challenges and healthcare gaps. Doulas often recognize when a mother or birthing person is struggling emotionally and can provide or suggest support accordingly. They really fill in the gaps in healthcare by being available when doctors or nurses are not. A quick text or a call with a doula can help a new mom or birthing person decide what they want or if what they're experiencing is normal, or if they should see a doctor, thus potentially catching complications early. They really promote culturally affirming care and informed decision making. Culturally affirming care means the mother or birthing person's cultural language and values are respected in the care process. Doulas can translate medical jargon into familiar language or advise on how to incorporate cultural practices safely, like certain birthing positions or postpartum traditions. This makes mothers and birthing people more engaged and comfortable in their care. Informed decision making is also key. When mothers or birthing people understand their options, let's say pain relief choices in labor, or whether they want to induce labor at a certain point, they can make the choices that are best for them, reducing regrets or trauma. Doulas are educators in this respect. Doulas really encourage active participation in maternal health journeys instead of being a passive patient. The mother or birthing person becomes an active agent in their health. With a doula's encouragement, they might speak up more at appointments, set birthing plans, or pursue services that they otherwise wouldn't have known about. So expanding doula access and care for hospitals or clinics, they should definitely start integrating doulas into their practice or at least partnering with doula organizations. An OBGYN practice could have a referral list of certified community doulas interested in patients. Policies makers can help fund by funding doula training programs, particularly in underserved areas, and by creating incentives or grants to support the growth of community doula organization. So the closing thought that I want to leave everybody is with, we can reimagine maternal mental care systems that generally serve all women or birthing people by supporting interventions centered on community culture and empowerment. The last thing that I just want to show is that it was Black Maternal Mental Health Week in July from the 19th to the 25th. And it definitely says that 40% of Black women experience maternal mental health symptoms, and that's nearly twice the rate of all women. Thank you so much for for listening to my presentation. I hope everybody has a great day. If you want to contact me, this is my email and this is my phone number.
Thank you, Dr. Finn. We do have some really great questions in the chat, if you don't
Okay.
mind. Um,
Sure.
yeah, bring a few of them. One of our first questions that came in was just around how much the disparities are there for women of color, and how can we step in, like as mental health professionals and clinicians, to address these gaps?
I think that we definitely need to make sure that we're checking on our moms and our birthing people. And I use the word birthing people because people who are not moms can also give birth. So that's why we say the language birthing people. Surrogates can also be considered as a birthing person because they don't want to be called mom. So when I say birthing people, it's inclusive of everybody. So moms and birthing people, we definitely need to be checking on them and making sure that we're really having these conversations about how they're feeling. A lot of women of color feel like they are going through things in isolation, and sometimes they don't ask because they don't know. You know, the more that they know, we can also educate them on different things. Like, for example, what postpartum depression looks like versus, like the baby blues. Having those kind of conversations definitely help so that we can be able to, service our clients.
Yeah, definitely. Thank you for that. And we had two more great questions here. Before I wrap up, I am sharing some really great information on our screen, but I want to ensure that we are covering our questions here as well. So please be sure to look at your screen, and of course, I'll wrap up with this after our questions. So we had a question here. We know there's been some changes due to Medicaid. Are you able to answer this question? If you're aware, how will future cuts to Medicaid link to this national bill just passed? And, these are.
I'm going to be honest, I'm not too sure. I'm still trying to do my homework on it, but I definitely know that with some of the organizations that I have worked with, their federal funding has been getting cut. So I know that there's definitely going to be ramifications with the cutting of like Medicaid. So I'm just trying to like do my research so that I can kind of be ahead of what's going to happen. But there's definitely cuts already being made. So it's a little scary for our doulas and birthing services.
Yeah, definitely. And that's something that we can do ourselves as clinicians,
Mhm.
do our research, because it is something new. We haven't seen, we're seeing some changes, but not all of the things coming into effect just yet. So Thank you so much for this question and giving us some insight to that as well. One last question here. What other resources could we offer as clinicians, counselors, like if Ashley stepped into our office? What could we do for her as a
So
counselor?
that so that's so funny. Ashley is really a client that I have, and I was the person who connected Ashley to actually doula. Ashley just had another kid. So this kid now she had with a doula, and the doula and me together kind of make sure that she had all the resources that she needed. So for example, we should be able to have doulas on hand, midwives, any of those people, just so that we can offer those resources. I myself am in the process of becoming a doula. I really talk a lot about them, so I felt like I should take the training just to understand, the concepts and different perspectives that they have. So I would say for us, we should definitely also have those resources so that we can educate too on these services.
Yeah, thank you so much for that, Dr.
No
Finn.
problem.
Definitely being aware, like if you can connect with doulas in your community, in your area where your clients are at,
Mhm.
so that you're able to educate yourself or educate your clients and get this advocacy for them. Thank you for that. Um,
No problem.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.